Yes, thank you all for joining our October Information Exchange meeting on this very interesting topic on updates, like the latest COVID-19 updates on access to GP services. We have two great speakers again, Richard Bull, the program director at Primary Care NHS North East London Clinical Commissioning Group, and Dr. Vinay Patel, the chair of Hackney and City Local Medical Committee. And he also is practicing at Stamford Hill Group Practice as well. Our guest speakers will really give us, as I said, very important information around access to GP services in Hackney, but they will also talk about the pressure over staff at the practices, perhaps how we can help release a bit of this pressure as well, and some other very useful information. If you have any, I will appreciate it if we all wait for their presentations to finish before we ask any questions. If you want, you are welcome to use the chat function of the meeting, of the Zoom. It's just at the bottom of the screen. Please use it there. We'll definitely take questions and answers, as I said, after the end of their presentation. You can also use the reactions button as well. If you want to ask a question, you raise your hand. And if that's okay with everyone, I will give the word to our first speaker, Richard Bull. Hello, Richard, and thank you for joining.
Hello, Canaria. Thank you for inviting me. Great to be here.
Thank you.
So when Canaria invited me to come to this meeting, she said, Richard, can you come along and give some reassurance that services are running as normal? Well, yes and no. I can certainly reassure people that general practice, which is the area I cover, is open and busy and seeing patients, and is probably busier than ever. However, things aren't running as normal as in a few years back, and I think nor will they ever be. I think the model of primary care has changed, and that change is partly in reflection of what the government, NHS England, wanted to see by way of change, wanted to see primary care developing, evolving. And part of it is in reaction to the COVID crisis. And I think what the government wanted has been accelerated by the COVID crisis. The government wanted to address the problems with primary care in terms of there just aren't enough GPs by expanding the primary care workforce, so including new roles. And these are great roles. These are valuable additions to the primary care team, and they're great. They're a great resource for people to use, for patients to use. So I think gone are the days where your first port of call for anything undifferentiated would be go and see the GP. Now you have a much wider range of options, people who are potentially better suited to meet your needs than the GP was. I mean, part of the plan is just that, as I say, the recognition that there just aren't enough GPs now. So we have had to diversify. And the other change is the idea that the first time you get across to the GP or the person in front of you, the nature of your appointment, why you've come to see that healthcare professional, the point at which that comes across will no longer be when you arrive in the GP surgery. The idea now is that everything will be triaged in advance, to try and direct you to the right person, whether that is the GP or the nurse or the first contact physio or the social prescribing link worker or the clinical pharmacist, a whole range of additional staff. So it's very important that the person's directed to the right person to meet their needs. And if you remember thinking about running as normal, many years ago, access to general practice, you had to sort of, it was a bit of a lottery really in terms of whether you could convince the receptionist that you needed a GP appointment. I think by this triage, you're sort of making access much fairer for people. Everybody gets some sort of assessment, pre-assessment of what their need is. And in the very, in the very bad old days, access to primary care was determined by you queuing up in the morning. And if you were first in the queue, then you were first to be seen. So it's great that the bad old days, the worst of the general practice model, I think that's changed, and I think it's changed for the better by triaging first, so you can direct to the right model, but also diversifying the GP workforce. And when Canaria invited me here, she said, "Can you give some reassurance that services are running as normal?" And also sort of knock on their head this myth that GPs aren't seeing people face to face. Well, clearly GPs are seeing people face to face. That's not in the same proportion prior to the pandemic. And that's because a lot of care can now be delivered safely remotely. It's great that the patient doesn't need to go in person into the GP surgery to see the GP, the nurse, the first contact physio, etc., and that care can be delivered safely and effectively either on the phone or on the video. It's mostly by a phone. We don't know at this point in time exactly what the right proportion of face-to-face to non-face-to-face is. That's determined very much by the individual needs of all the people that belong to a practice and the sorts of issues that they have, but also the practice team as well, what the practice can respond to. So that pendulum swung very far to one way, one way during the pandemic, when GPs were actually told by the government, by NHS England, you need to really reduce footfall into your surgery as much as possible and do as much. And to do that, do as much on the phone as you can. So that was the clear message to GPs. GPs didn't dream that up themselves. They were told to do that. Now the pendulum is swinging back to more face-to-face. Where the pendulum is eventually going to land, we don't know at the moment. And I imagine, I'm also convinced actually, that's going to look different for different populations and different practices. So GPs are open. They're busier than ever. You won't necessarily see the GP, but you will see a qualified member of the practice team, and you almost certainly, your first contact will be remote, and you will be brought in for a face-to-face appointment where there is a need to do so. So I think general practice has changed. It's not going to be going back, and that is the new model. And it's really important that we engage with patients on that new model. Because without that patient engagement, I think there's going to be this continuing perception that GPs are making life difficult for patients when they're really not.
Thank you. Thank you very much, Richard. I'm sure we will have some questions related to what you just said, but we'll give the word to Dr. Vinay Patel. As I said, he is practicing at Stamford Hill Group Practice. And one of the reasons, obviously, for him to be here is to tell us how things happen from the GP perspective. And Dr. Patel, if you can really quickly say a few things about yourself as well, and describe the working conditions in the surgery at the moment. Thank you.
Thanks, Canaria and Richard. I'd forgotten those queues at 8 AM actually. Yeah, I think times are slightly better than that, waiting in the cold, aren't they? So thank you so much for inviting me to join you today. I really appreciate the opportunity to engage with you all in this forum. And the first thing I want to say is that our GPs in City and Hackney and further afield as well share some of the concerns and frustrations that all our residents are experiencing at the moment in terms of accessing the healthcare that you may feel that you need. We really do want to be able to provide more appointments. We want to be able to provide longer appointments. And we do want to be able to see you all face to face where appropriate, because honestly, it actually does make our job a lot easier. If we can see somebody and examine them and make the correct management plan. That takes a lot. It's a lot quicker to do that with you in front of us than on the phone and having to ask lots and lots of questions to really understand an issue on the phone. We also don't want to have to deal with your complaints or leave you unsatisfied with the service you received, or really want to have to discuss with you why it took you so long to reach us, rather than actually talking to you about how we can help with your medical problem. So all of our GP surgeries in City and Hackney have been open and accessible throughout the pandemic. But as Richard has outlined, perhaps not in the traditional sense that you've been used to for so long. We've moved to telephone triage and consultation, and they are two different things actually. So if you do speak to a healthcare professional, they're not always triaging you. They're not always trying to be quick and put you with the right person. It is also a consultation, so you can have a detailed conversation about whatever the problem is. During the height of the pandemic restrictions, we had to have quite a high bar before we could bring somebody in. As Richard said, we were mandated to try and manage things remotely as much as possible. And of course, the reason for that was that if we had to bring somebody into the surgery, we had to guarantee that we could do that contact in the safest possible way for both our staff, for that patient, and also the other patients that may be in the building at the same time. Fortunately though, over time, as the COVID situation has improved, vaccination rates have increased and lockdown restrictions have eased, we've effectively been able to lower that bar for bringing patients in for an examination. And remember, as I said before, that's what we want to do. It helps us and it makes our job easier and means that we can manage you better. However, we've continued a telephone first model so that we can offer a remote service to those patients that actually prefer it. Prior to the pandemic, there were a few practices in Hackney that had already adopted this model, mine included. And we found that those benefits that those practices realised are now being seen by other practices that have taken it on board because they had to. And some patients actually prefer it. As Richard was saying with the queues at 8 o'clock, the other thing that I remember is that in the old days of 10-minute face-to-face appointments as our only access, the waiting rooms were quite full. GPs are often running behind. It may mean that you had to take a half day off work to come and see the GP, irrespective of what the issue was. It could have been a very quick issue, or it could have been something more lengthy, but your time, you had to allocate the right amount of time. Now, if you work, we can call you around about a time that you might be available for a chat, and we can potentially deal with the whole problem on the phone, send a prescription to a pharmacy, which maybe you could pick up on the way home. If we need to see you, we can, and we can discuss with you a mutually convenient time, which usually requires minimal waiting time in our waiting rooms. This also reduces the number of people waiting in the waiting room, enabling us to maintain social distancing and reducing the risk of illnesses being spread across our waiting room. Remember, you might be sitting next to somebody with cancer, with a learning disability, dementia, heart disease, these conditions, which can be really badly affected if they were to catch something unnecessarily. The other advantage of this model is that actually most practices have been able to increase the number of patient contacts each day, because switching from face-to-face to telephone means that each GP can have more patients on their list. So you actually have more access to your GP per day at each practice. However, what we've seen in recent months is that the demand for seeking general practice services has significantly increased compared to the levels that we saw before the pandemic. There's lots of reasons for this, which I won't go into, but we are struggling. And this is a national issue. It's not just us locally. This is absolutely a national issue that we're working with. As a result, locally, we've been working and building on some of the work that was already going on before COVID hit, primarily in terms of diversifying our workforce so that we can offer you the right professional for the right problem. So while GPs can do a lot of things, and we're experts at a lot of things, we're not always the best for everything. So now every practice in City and Hackney has access to a clinical pharmacist. They can discuss your medication queries and even manage some of your chronic health conditions like diabetes, asthma, heart conditions, many more. We've all got access to a physiotherapist now, so they can see you for any muscular or joint issues you have. They have more time to spend with you than we would in a 10-minute appointment, and far more specialist in-depth assessment of your issue. If they need a GP at any time, they'll just ring us straight away, and we can come in and help as needed. We've got wellbeing practitioners. They're seeing some of our most complicated patients with extended time to spend with each of them. Because again, GPs can't always spend 30, 60 minutes when it's required. Social prescribing link workers who can help with your concerns that may not be directly medical, but are affecting you in your lives and possibly your health. And they've got a whole suite of skills and options to help you that GPs just don't have. We've also been communicating with our community pharmacists, who are now trained and skilled to see you first for a whole range of conditions, instead of having to see the GP. And they'll contact us directly if they can't deal with your complaint themselves as well. So we're working together now as an entire healthcare system in City and Hackney to ensure that we can improve the way we provide healthcare to you by increasing our capacity and offering you the right specialist for the right problem, not just the GP every time. Our receptionists are all trained to recognise which patients may need a pharmacist, a GP, a physio, whoever. So that's why when you call, they will probably ask for a headline as to why you're seeking a consultation that day. And they may offer you an appointment with somebody that isn't a GP. So essentially, this means that GPs can concentrate on seeing those patients who really do need our expert skills, managing the more complicated cases and the more severe symptoms, which some of the other clinicians I've just described wouldn't necessarily be able to do. Now, despite all of this work, we still don't have the capacity to fully meet the demands on us. So sometimes your surgeries will tell you that they're full. In City and Hackney, all of our surgeries offer an incredible service called the Duty Doctor service, which I'm sure most of you have heard of. It should be advertised on all of our websites. This essentially means that if we are full, we're available to answer any urgent clinical queries from our patients. So if you are told that you're full, you can ask the receptionist, sorry, if we're full, you can ask the receptionist if you can use the GP Duty Doctor service. And then our GPs are trained, experienced to recognise when a problem's urgent, and will absolutely fit you in for a phone call, examination, if required. Now, this isn't a guaranteed way in, but it is an offer that we have in City and Hackney that a lot of other areas don't. When other surgeries are full, that's it. There's no way in. You have to try again the next day, go to A&E or whatever. But we're committed in City and Hackney to ensure that those that absolutely do need urgent healthcare will do. The final thing I want to say is to echo Richard's comment to reassure you all, the general practice is open. We're here for you, and we really are working very hard with our practices and the wider healthcare system to improve the services that we can offer to you. Thank you.
Excellent. Thank you, Dr. Patel. Maybe it will be good really in this order to mention the Extended Access Hub. I think it will be useful if you say a few words about it.
So this is a service to provide GP consultations primarily. Richard, you'll tell me if there are other professionals doing it. I think it's certainly locally, it's in my area of Hackney, it's only GPs before 8 o'clock in the morning, before work, which is great. Our uptake of those appointments is always very good. And also after work, usually between 6:30 and 8 p.m. So when you call your surgeries, you can ask for an extended access or extended hours appointment, and all surgeries have access to those appointments. Occasionally, it may not be a GP at your surgery that calls you, but they do have access to all of your healthcare records. So they will be able to look at your results, your letters, your past consultations, issue medications, all of those things. yeah, a great offer locally. Thank you, Canary.
And is it right to say that these appointments are available until 8 p.m. on weekdays and on weekends as well?
Yeah. So 6:30 to 8 p.m. on a weekday, and 8 till 8 at the weekend. Is that right, Richard? 12
Yeah,
hours?
8 till 8 at the weekend, and it's almost all GPs at the weekend.
Excellent.
Might be more of a mix in the week.
Yeah. All right. I think that's useful for people to know that there is another option for them to book an appointment in a time that perhaps will suit them more than during the day. Thank you very much. Any questions? We have one comment in the chat box, and I will read that now. Can I ask a question around Richard? He said, we don't need to always see a GP, but we can go anywhere we want. What does he mean by this? Still can't get appointment when you go online, still have to book by 8:30, I guess 8:30 a.m. Richard?
Yeah, thanks, Canary. I can't actually see that in the chat box. Perhaps that's my...
Oh, yeah, that came to me directly.
Oh, I see. That's why. When I said you don't always need to see a GP, it goes back to the point that Dr. Patel made, that actually now there are other members in the practice team who might be better to meet your needs than the GP. The GP is great at a huge amount, but actually, the first contact physio is a specialist in physiotherapy, much more so than the GP. So, if you've got, knee pain or elbow pain or something like that, it might be that the first contact physio is better to meet your needs. That's what I meant by that.
And I hope that's clear. Thank you very much, Richard.
Can I just add to the first contact physiotherapists? Actually, they are physiotherapists by training, but they have had additional training. So they are not there to only offer physiotherapy. So some of the pushback we get is that I don't want to see a physio, I don't need physio. They're actually trained to recognize all musculoskeletal issues. If you were to need blood tests or an X-ray, they can arrange that and interpret the results as well. They can recognize when a back issue is not a muscular issue, maybe a kidney issue or something like that, maybe start some planning or investigations and link in with the GP. So if you are offered that service, you're not being offered a traditional physiotherapy service. Right,
thank you. Thank you very much. Malcolm, our chair, would like to ask a question, I guess. Malcolm?
Thank you very much. I don't think we have any doubts about the commitment of local GPs to the providing excellent services locally. I'm very worried about triage and who's doing it, because it seems to me that we're asking people who have no medical training or clinical training to make decisions on our behalf when we phone in and say we're being asked to explain our problem to somebody who's not clinically qualified, and I find that rather appalling, to be honest. I think triage should be done by people with clinical knowledge who can therefore help us to make the right decision. It also seems to me that, I know why, it's because of COVID. It does seem as if there's been a kind of a revolution in primary care without the NHS constitution being considered, which says that the patient is at the heart of everything we do in the NHS. And it seems as if this is sort of moved on, and the patients, I speak to lots of people who just seem to be totally confused about what's happening in the system, and every practice seems to be operating differently. So those are my concerns. I'd be very grateful for your comments on those.
Thank you, Malcolm.
Shall I answer from a GP perspective? So thank you, Malcolm. They are legitimate and fair questions to ask. So you're right with triage. Who's doing it? How are they doing it? How at your end can you trust that they're doing it appropriately when you call expecting a certain outcome, and perhaps they're offering you something that you didn't expect or may feel is not really what you requested? So we do work very hard in training them. In my practice, we have the duty doctor working in reception. So they're kind of listening to phone calls, fielding phone calls. They're on hand immediately. So if a patient gives a headline and the receptionist isn't exactly sure what to do, there's somebody there right there and then before the phone goes down to address that concern. I would expect a similar approach in most practices across the borough. If we look at things like the physiotherapist or community pharmacy, they have worked hard at their end to help us. So they have developed a list of presentations or headlines that patients may say in terms of helping our receptionists recognise those and point them in their direction. We also have worked hard on the feedback loop. So if we do get it wrong, you're not left. You don't have to be too inconvenienced. They, you know, a community pharmacist will call us directly at the surgery and we'll get a GP if it was incorrectly put there, and similarly with the physios or pharmacists in-house. And triage is a tricky thing as well. So some practices, their GPs do the triage. So some practices have online as the first access point. So they, if you need anything from the surgery, you'll submit an online form. They'll help you to do it if you're IT illiterate. And so that they look at everything that's come in, and a GP will scan all of those requests. So in that model, you're having a clinician there at the first receipt of the request. So there's a few different ways of doing it, and there's almost a quick triage step and perhaps a more detailed triage step with more information, which perhaps that model with the online form provides.
Thank you, Dr. Patel. Would you have anything to add, Richard?
Just a reminder again of the bad old days, really, when you sort of had to get past the receptionist to get an appointment, and quite often you felt as though you had to sort of like inflate the nature of your problem to get an appointment. But I think with triage as it's happening now, I think it's much fairer. You know, the GP can quickly scan all of those online requests and easily filter out those that are admin or for, you know, somebody else to deal with. It just feels much fairer. I recognize that online is not suitable for everybody, so there needs to be, you know, fair access for all, whether that's phone or people coming in still face to face, and also practices helping people fill in online consultations as well where that's required. Going back to what Malcolm said in terms of, you know, patients are confused. I'm not surprised that patients are confused because there's been a huge amount of change. Everybody's confused, more confused these days post-COVID. I think we're all sort of adjusting, aren't we? We're all having to make adjustments, and general practice has changed, and I think it's going to take people a while to catch up with that, but also we need to actively engage with patients as well to help them make the best of the new model of primary care, because it is here to stay. It will continue to change itself as it settles down, but you know, I'm not surprised that people are confused, because it is incredibly confusing.
Thank you.
Okay,
Richard.
thank you.
Thank you. And yeah, we were talking about triage over the phone and online access. And obviously we appreciate that not everyone has access to online services or access to internet. But what about people who are hard of hearing? Perhaps we have one of these questions here in the chat box. Someone either says, I have real concern for people who are not able to go online or are hard of hearing, which automatically make the telephone triage or telephone appointments very much unsuitable for them. Are they still able to just walk in and book an appointment or request to see a consultant?
We have a list of our vulnerable patients. Could be many different things, and hearing impaired is one of those things, sight impaired, lots of other things, mobility issues, whatever it is. We have alerts on their records. We're open at the front door. We're obviously open for relatives. We won't give them a telephone consultation if it isn't appropriate. So we will give them face-to-face access. We've got equipment in the surgery as well. I forget the name of it now, but it helps us to communicate with these patients as well. So we do have access for those patients. And that should have been communicated with them, really. So we did some work to let them know early pandemic, really, when we had to address these things more urgently, we proactively contacted these people to check in on them and let them know how they can and should access services with us.
And I guess when you say we, you mean the Stamford Hill Group practice? Or...
In an issue like that, I'm speaking personally from experience in my practice. I would expect most to do that. So whoever that question came from, I would urge them to speak to their practice if they're not aware of the best access route and what would happen if they access or need access.
Okay, thank you very much. There is another, is a thing about, it's a complaint, I guess, about Stamford Hill practice, which I will read in a minute. But there is something else that I wanted to ask as well. So Richard was, and it is again in the chat box. Let me just very quickly. Richard mentioned that there aren't enough GPs. Are there national plans to increase recruitment through increase in training places? And also that's linked to the stuff that we've been hearing, that many staff members are willing, they want to leave health jobs because of the pressure over the last couple of years. Is that an issue in Hackney?
It's an issue up and down the country, and equally it's an issue in Hackney. Happily, you know, we have a very good GP to patient ratio, but you know, that is under threat from the constant pressure on practice staff, not just the GPs but all of the practice team, due to high workloads and burnout, etc. I completely agree with Shirley's point in the comments about don't believe the government in terms of, you know, plans to increase GP numbers. Things are happening. You know, training places are increasing, and there are support schemes in place to, you know, encourage GPs to stay, to support people coming into the profession, you know, supporting salaried GPs, etc., through peer support and additional, you know, additional training, other opportunities. So all of that is, you know, all of that is there to help. But you know, some of it feels as though it's a panacea. It's doesn't really address the fundamental workforce crisis, because there really is a workforce crisis. We have to be absolutely open and honest about that.
Okay, and Dr. Patel, I can see that you've responded to the comment about Stamford Hill, but I will read it loudly just because I know we have members of the public who have visual impairment. So as a patient of Stamford Hill surgery, anytime I try to book an online appointment, there are never appointments. When I call to book, I'm told to ring back at 8:30 a.m., which when I eventually get through, all appointments are gone. The receptionist might be trained. However, some of them aren't trained in sensitivity. To me, it's stressful to simply try and get an appointment. Also problems with prescriptions and them not being processed. When I had no medication, the attitude was, oh, well, do you have any way to measure first contact with the surgery and how this could be improved? Dr. Patel, would you like to respond to this?
Yeah, thank you, Ali. I completely sympathise with what you're saying there. It is very difficult. We have a very large practice. We have specific challenges in our area and capacity demands as well. So as I've said in the message there, we open up our pre-bookable appointments a day before, and issues with reception, with processes like getting medications issued, we are working very hard on, we're giving our receptionists more and more training. We are looking at processes. We have a meeting where we discuss errors that we're making and things like improving how prescriptions are dealt with. You know, if people are, you know, if you go to, I expect what's happened is you've gone to the pharmacy and it's not there, or the wrong thing is there, and we do talk about those things internally. It might not help you as somebody that's experienced that directly yourself, but we do try and work hard to share when those things have gone wrong, to work out where the issue happened within our building. One thing with reception is that they have an incredibly busy and difficult job, particularly the first 2 to 3 hours of the day. They are constantly on the phone trying to deal with any issue at all that patients are experiencing. We've done a lot of work. One of the queries is around measuring the first contact with the surgery. So we're in contact with our phone provider, because I think we highlighted that there was issues on the phone where calls were being dropped. So we've worked really hard to try and understand how many calls are coming in, open up more phone lines and get more people on the phone, particularly that first hour of the day, 8 to 9 o'clock. Unfortunately, the downside of that is we get full quicker. So we're often full by 9 o'clock because actually we've got more people answering the phone first thing in the morning. So that's almost the next wave of what we need to do. And it all feeds back to what we were saying earlier about diversifying the workforce. Previously, we could only book you with GPs. So in effect, we'd have been full even sooner. At least we have a bit more scope to ask pharmacists, physios, community pharmacists, whoever else to try and help meet some of that demand. And again, we've got the duty doctor as well for urgent queries. I appreciate that doesn't help if we tell you it's not urgent for that day, and it may be the third day that you're trying this, but we are trying our best.
Thank you. Thank you, Dr. Patel. And you kind of covered the telephone side of Cynthia White's question, but I'll again read it loud. What measures are systematically taken by GPs to ensure they know how their systems are actually working at the base level, receptionist? I have evidence where a clear gap has arisen leading to multiple patients' complaints, everything from staff failing to wear masks to inability to book appointments, informed reception staff, and therefore wrong information given about ancillary services available. Yes, so I guess, as I said, you've kind of like covered the extra role given to the receptionist in terms of how they can signpost people, patients, which, as someone who speaks to different members of the public almost every day, and I often hear how they say, oh, who is the receptionist to ask for my problem? She's not a medically trained person. And I really understand this frustration because the information is not available for them to know that receptionists are actually given this extra role. So would you have anything to respond to Cynthia White's question, Dr. Patel or Richard? How do you measure if your systems are actually working?
I mean, I can kind of expand on what I've said already from a personal point of view of my practice. I don't know these kind of operational aspects in other practices, but generally we'd probably approach things in a similar way. So highlighting errors when they happen and investigating those and working out within our teams how we can improve things. With reception, we give them a guide to follow. So there's kind of 5 key questions that we ask them to ask. So when they speak to a GP, we've got a head start in terms of the advice that we're giving them and the information that we need from them. I'd expect most practices do that. And again, it's really important with receptionists who are not medically trained that we continually train them. Every month we have training sessions for them talking about difficult conversations that they've had with patients, difficult interactions, situations where they've felt stuck and not actually known what to tell you. And we're trying to help them dealing with those situations as they arise as well, and to help them do better next time.
Thank you, Dr. Patel. I agree. I hear what you're saying. And it's good that you speak to, when you say you, I mean that the City and Hackney GP surgeries and practice managers, that you speak to the receptionists and try to understand what pressures they have and help them. And this is fine from this side of the work. But I think the problem is with patients who don't actually know about these new the new role of the receptionist and how this is communicated with people. Because even if over the phone, the receptionist quickly tells, by the way, just to let you know that I can signpost you to other services should, you know, depend on what information you'll give me. I hope that's okay with you, or something in this order. I think that will really help people to understand why this is happening. Richard, you wanted to say something?
Yes, I'd like to respond to Cynthia's question. First of all, hello, Cynthia. Nice to see you online. I hope you're well. I think GPs, the management team, they rely on patient feedback, don't they? If things aren't right, then they rely on patients to speak up and say things aren't quite right. And that can be done informally, or it can be done formally. I'd encourage patients to do that informally. You know, where a receptionist has got something wrong, if they should have known, you know, the existence or the timing of a foot health clinic, then if they got that wrong, they should be told. And all of that helps the practice to improve. But also, it's, you know, it's beholden on the practice. The practice, you know, is responsible for its own internal workings and runnings and management. And you know, it's important that those systems are right. And I think that can only help by getting that soft intelligence, that feedback loop from patients to continue to adjust and improve. I recognize sometimes there are real or perceived barriers to giving feedback, either, you know, informally or formally. But hopefully patients can speak up where there are problems.
People can always really reach out to us as well. We're more than happy to hear
and be a help.
And pass on any concerns to the service providers and Richard Bull as well when appropriate. Thank you very much.
There's one other flag we haven't mentioned as well. So annually there is the patient satisfaction questionnaire. I think the questionnaires go out early in the year, and we usually get our results around June or July. And that's a big moment for practices, looking at that data and analysing things, comparing it to the year before and seeing what further improvements we need to make, what challenges are our patients experiencing. So actually, that's a very important thing in terms of us seeing feedback on a larger scale and being able to try to implement changes to help the system.
Thank you, Dr. Patel. Shirley just added something. Cynthia's points. Shouldn't the GP forum and also the federation get involved in this? And how about making it possible for patients to contact the GP forum directly with that sort of information about system failure? Richard or Dr. Patel? Is that possible from your view?
We certainly need to make sure that the patient voice is heard through the whole system, whether that's direct to the GP forum or not. I'm not sure, but clearly.
Or at the PPG meetings.
Making sure that via the PPG meetings, via the PPI committee, etc., all of that is fed up through the system, and that used to be fed up through the individual, you know, the GP leads, through their consortium leads, and that needs to continue via the new structures, so via the PCNs and the clinical directors, etc., all feeding up through the system.
Excellent, thank you. Any further questions? Oh, Cynthia, you raised your hand again, or you were on mute, Cynthia?
Could I, thank you so much, Richard and Dr. Patel. Because I chair the Older People's Reference Group, much of what I say relates to older people and people who have difficulties. I'm afraid that I don't like the term IT illiterate. There are a lot of people who know how to use IT, but have physically become less able to do it as they age. So let's just remember that. But I'd like to try and square up a current television advert with what is happening at local level, because it might be public are being misled or led to have their expectations managed rather differently than you would find helpful. And that's the series of ads. I don't know, I can't think where they come from at the moment, but they're official ads. I think it's NHS, but it's showing different patients saying, a little niggle in my tummy, or I did see just a little bit of blood, and so on. About half a dozen of those little tiny cameos. And the message at the end of it all is, it's probably nothing to worry about, but what you should do as soon as possible is to go and see your GP. Are you going to be able to do that? I mean, millions of people are seeing these ads. What are they going to get? A receptionist who said, you've got a niggle in your tum. How about seeing the pharmacist for a bit of Gaviscon? I mean, what actually is the reality?
Thank you, Cynthia. Dr. Patel.
Thank you, Cynthia. That's a great question. The receptionist will ask what the problem is. So if we use the example of a little niggle in the tummy, they may ask how long it's gone on for. They may ask how severe it is. They would ask very basic, open questions. If it's been maybe a day or two and it is downplayed, then perhaps a community pharmacist might be the first port of call. That means they are getting a discussion with a healthcare professional who either will give them perhaps Gaviscon or something else over the counter, with the caveat of, if this doesn't improve or if you don't see these symptomatic improvements over this defined time, please call back your surgery. A lot of the time that may do the trick, or if they do come back to the surgery, if they say they've already been to the pharmacy before and we'll have a note to say that that's happened, that won't happen a second time. There's a different story there. It may be 4 or 5 days, symptoms may have changed or progressed. A second example of blood being passed would be different. So that's effectively a red flag. So that's something that the receptionist wouldn't triage elsewhere. If we have GP appointments available, they'll be put on the GP's list. If we're full, that will go to a duty doctor without you having to ask for a duty doctor. So that's something that does need a GP to deal with. So when I keep talking about training of our staff, they are trained to know which headline conditions, because they can't ask you too much, the pharmacist is comfortable seeing because they've talked about it and given us a list. Which ones the physio is comfortable seeing, again, because they've talked about it and given us a list. And then which ones we as GPs say absolutely need to come to us even if we're full. Things like bleeding from the back passage, perhaps chest pain, breathing problems, irrespective of your age, certain things like that. And also certain patients. There are certain patients that we say never ever tell this person we're full. Preferably come and see me because I've known them for a few years, but if I'm not available, make sure a GP speaks to them today. And that we call them vulnerable patients because it encompasses lots of different ways into that, essentially. So hearing impairment, as we talked about, maybe physical disability, maybe lots of multiple conditions, heart conditions that are severe, or stroke or anything like that. So encompasses a lot of those things, and patients we absolutely don't want to turn away or ignore.
Thank you, Dr. Patel. And Malcolm, you raised your hand again, and I think we'll get your...
Oops, am I? Yes, thank you very much. Just one last thing is, going back to the receptionist issue, I mean, is there a consistent training across practices? I mean, are all practices operating to a single set of guidelines about the training of receptionists? And, you know, it seems to me that in different practices, very differently. In fact, we produced a report on reception staff a while ago, which you may have seen. But I do wonder whether there is a consistent approach to training and development.
Didn't hear all of that, Malcolm, but
I'm sorry.
the end of it, and that's the main thing, isn't it? You're asking about whether there's a consistent approach to training receptionists, and I think
training and development of receptionists.
Yeah, I don't think that there is at the moment. So practices take it upon themselves to improve things depending on how things are working, what the staffing levels are, staff skills, staff mix, etc. How many complaints and issues are coming up, process issues like the medication example that Ali mentioned on the message. I think that's something we could actually take away, looking at how practices are training receptionists. Where can we streamline? Where perhaps should we set some uniform goals across the borough to make sure we're providing a consistent service or a consistent level?
Is this not an obvious thing for the GP Confederation to be involved?
Can I come in?
Yeah.
I suppose some of that is in place in a way. I mean, training is offered to all practices via a number of sources, e.g. the local training hub, the GP Confederation. So a standard of training, the same offer is available to all practices. So if practices are available, avail themselves of that offer, then that training is there to the same, everybody gets the same thing, the same standard. In terms of, I suppose that is my point. I suppose the Confederation and the Training Hub already have some sort of agency there.
Thank you, Richard.
Thank you very much.
And Ida, did you? Okay, all right, that's fine. So we don't have much to go really. I would ask maybe Richard and Dr. Patel if you have any final words to say before we finish the meeting, or any other burning questions. Shirley has her hand raised. Shirley?
Yes, thank you. I mean, following on, Malcolm is kind of emphasizing some of what I was saying. I think it should be, I think the Confederation, in my chat note, I said the Federation, I probably meant the Confederation. I think the Confederation and the GP Forum should actually agree to, with presumably the agreement of their members, take on the responsibility of being proactive about investigating things rather than waiting for I mean, Richard says they've got agency. Well, you know, what are they doing with that agency? It seems to me they should be proactive. And that is why I think patients ought to be able to have direct access to either or both of those organizations, depending on which one somebody here says is the better one to go to. I'm not entirely sure of all of what each of their roles are, but it seems to me, you know, we have to be able to get above the actual GP thing, because clearly there are things going wrong. I mean, just briefly, the caveat is that we know they're under a lot of pressure. Okay, we do, most of us. There are some people who are just so ignorant and impossible that, you know, they're not taking any account of the pressures that the whole of the NHS is under. We realise that, and maybe abusing staff and so on. But even so, that we need to be able to get above the GPs, plural if necessary, who are consistently failing.
Thank you, Shirley. That's quite an important comment. Thank you very much. Cynthia, and very quickly from you as well.
Thank you. Just to say at the end, and it's also a question which goes to social prescribing, because we understand the shortages of trained personnel right across health and social care. But the stats before COVID showed that some 60% of people going to GPs went because they were depressed, needed reassurance, wanted that physical human contact. It was the most valuable medicine that they could be prescribed. But everything that's happened since has increased social isolation and everything flowing from it. So I would just ask whether social prescribing as a parallel way of getting people what they need on the contact front is still being pursued as vigorously as before COVID.
Thank you, Cynthia. Would you, Dr. Patel or Richard, have anything to add on this, or would you like to? I think Ida wanted to very quickly say something as well. We'll have another minute for you, Ida. Is that okay?
Okay. I just want to ask a question. Could we not publicize what is available within newspapers or something? You know, we have papers going to houses. So I think that's one way of comms doing something. And the other thing is, you know, GP Confederation, if I remember right, and I think Shirley is asked that, there was some money given to specifically train a receptionist. And I know that was before the pandemic, and I don't know what happened with that. So I know there was funding given to that. So there are some things which are not adding up here. I know you're under pressure, but then so are we, not knowing what to do with our own health. So if you want us to wait till we are nearly at the end of, then you have more expenses, that's fine. And referrals, we can't self-refer because there isn't a pathway to that. So how do we get people to understand what exactly, who can refer to what services, who is available at what time, what numbers we need to call. So those are the little 5 things you need to put in that paper to say, one is not the answer here. So you've got to know about the social care, how to go. So because some of the questions are for us about social care, some of it for healthcare. So we can't directly call social prescribing because we are not able to. So I think we need to know, how do we move forward?
Communication
if you
is
want us to
crucial.
support you, you need to support us to do that too.
Things have to be communicated, definitely. Any quick answers, Richard? To Cynthia's point and to Ida's point, I guess.
I really see the need for social prescribing. I'm sure it is, the social prescribers are there. I think the numbers are still set to increase. There's still additional funding coming through PCNs for these additional roles, including social prescribers. The need is huge, particularly, the effects of COVID, as Cynthia rightly points out. Social isolation has increased, but the strength of socialization of social prescribing is only as strong as the voluntary sector, because they're the groups that are there to support patients. So we need to make sure that the voluntary sector is in a robust position to be able to meet people's social isolation needs. I'm afraid I'm going to have to go. I've got another.
Thank you. Thank you very much, Richard. Thank you for joining and for the information provided. Thank you. I think bye-bye. I think what I really want to say is that obviously communication is crucial, and we as Health Watch would be more than happy to promote any health information that you think patients should know, as well as what Ida was suggesting, actually having this information newsletter that goes to different residents group and patients group as well. Was that correct, Ida? Just to let people know what's available, when it's available, and how to access the services. Thank you very much. Dr. Patel, would you have any final words before we finish the meeting?
No, I think this has been a really valuable experience for me personally. I really liked your line, Ida, that we understand you're under pressure, but we are too, and that's really, really important. So I'm hoping by engaging in events like this that we can have that two-way dialogue. Really hearing, particularly from today, what Malcolm, you said about reception training. I think Richard has outlined what's happening at the moment, but perhaps in terms of the changing role of reception in the last 18 months, that does need looking at again, because some of that I'm hearing the concerns that you're having, the trust in the process, the trust in the triage process. How do we know that you are trained correctly? So I'll speak to the Confederation about that point particularly. And Cynthia, I'm so sorry.
Oh, no, please go. Please go
just
ahead.
with social prescribers, they wouldn't ever replace that hand-holding contact that you were describing there. One of the reasons for our capacity issues is the awful mental health effects on patients for the last 18 months or so. The social prescriber is so valuable on the ground for helping in a way that we can't. So with social isolation, with group activities, with the voluntary sector, things that you wouldn't have had 2 years ago, because I didn't have access to those things. I didn't know about them. And in my 10 to 20 minutes with you, running overtime, I'm really honing in on your symptoms and whether I change your medication or send you to a psychologist. So they're not replacing that part, they're adding.
Thank you, Dr. Patel. And I know we overrun now, but I really want to ask this question. How do you think patients can help you actually as a GP practice staff and GPs and receptionists to ease the pressure that you all have? I mean, as Ada said, patients also have pressure, and you, I believe you do all your best to release this pressure, but what patients can actually do to release the pressure over the staff at the GP practices?
I don't think I could come up with something to say, all do this. It's about conversations like this. It's about conversations that we have at our end, that you have at your end, and it's joining that conversation. So what are we both struggling with, and how can we work together to move forward? So, the obvious thing is to say, don't ask for a GP every time, but that's not practical. On our side, we need more staff and more GPs and more capacity, and we're struggling there. So unfortunately, that middle ground we are struggling with on both sides. So it's just really about keeping on talking and changing things, a bit like what I said 2-3 minutes ago about some of the actions to take away from today, explaining what the other healthcare professionals are. I wouldn't say there's something that patients can do necessarily, apart from engage in the PPGs. We had a PPG for our primary care network of roughly 38,000 patients, and 6 turned up, all 6 of the regulars. So somehow we need to increase engagement. And I think the first step is the PPG. And obviously we've had comments about how we feed that into another forum, the GP forum or the Federation, wherever else. But the first step has to be the PPG, getting them more vibrant.
Yeah. Agree. Okay, I'm sure there are so many things to talk about it. That's not at the end of the conversation, but I really hope you all enjoyed that meeting. Dr. Patel, really grateful for your time and information that you provided. We'll draft a short report from the questions and answers and all the information as well, and we'll share this with you. We will also share the link to the recordings as well in 10 days' time. But thank you all for joining. Send us any questions, outstanding questions that you may have to the speakers, and we'll be more than happy to pass them on. I hope Dr. Patel wouldn't mind responding if any. Yes, thank you very much. Have a good afternoon. Have a good weekend as well. Restful and healthy weekend. Thank you,
everybody. Thank you.
Bye-bye.
Bye.
Bye.
Thank you.
Thank you.